Welcome, everybody. I'm still learning how to use video, I guess. I'm Eric Arzubi, Frontier Psychiatry, and have the privilege of working with this great team on our Project Echo for PRISM. And what we'll do first is introduce folks around the state. Cassie, you there?
Yeah, I'm here.
Great. So please go ahead and just a brief introduction.
Sure. I'm Cassie Bronson. I'm a women's health nurse practitioner student through Georgetown University. I live in Missoula, Montana, and my dissertation work is around substance use in pregnancy. So looking forward to kind of combining the mental health aspect with the substance use aspect.
Awesome. Thank you. Go Hoyas, Hoya Saxa. I'm also, that's my alma mater. Let's see. How about Betty?
Hi. Can you hear me?
Yes.
Okay. I'm Betty Strack. I'm a licensed marriage and family therapist. I'm about 90 minutes north of San Francisco. And I appreciate so much the information that Postpartum Support International offers. I've been able to use a lot of that information that I received from the two-day conference and passed on the websites and information to a couple of my perinatal females and it worked out really well. It was good to have information to offer.
Great. Thank you so much. Caitlin?
Hello, I am Caitlin Adamo. I am an LPPC, also in Missoula, Montana. I just a few months ago started private practice, fireweed integrative therapy, and have recently done that perinatal mental health training through PSI. Not currently certified yet, but soon.
Great. Thanks for joining.
Happy to be here.
Thanks. I'm going to pick on one or two more people, and then we'll introduce the panel, and then we'll go from there. How about I see a Robin Suzor?
Good morning. This is Robin Suzor. I'm the Montana EMS for Children's Program Manager with DPHHS.
Great. So what does that mean, EMS for children?
Emergency Medical Services for Children.
Okay, gotcha. Perfect. Thank you so much. I guess that's what I thought I meant, but I didn't know if that we had that. So great, thank you. Sorry for being ignorant. And how about Gavin Wisdom?
Hey there, my name is Gavin Wisdom. I'm with Partnership for Children here in Missoula, and I am managing a grant. We actually just recently settled on a new name for our project, which I'm proud to announce is called Project Welcome. And essentially we're serving folks in the perinatal period, so both mothers and fathers, and the pre and postnatal time, who are struggling with substance use issues and other mental health things. So yeah, excited to be here.
Thank you. You don't think they should have called it Project Wisdom? No? Maybe?
Not as targeted. We're really trying to go for that destigmatizing and that welcoming new humans piece too.
Nice. Yeah. Cool. Well, thank you. Great. So we'll turn to our panel. Bree, please go ahead.
Hi, everybody. I'm Bree McLaurin. I am the Director of Healthy Mothers, Healthy Babies, registered nurse, and PMADS survivor myself, mama of 3 in Helena.
Thanks, Bree. See Megan.
Hi there. I'm a LCSW therapist in Billings. I have a private practice, and I'm also a PMADS survivor. I have an 18-month-old, and so I am in the thick of it as we speak. And I'm actually just getting ready to test for certification next week. No, tomorrow. I'm testing tomorrow.
Next week. That's awesome. Megan, you gotta know when your test.
I know. It's
All
tomorrow.
right. Okay. All right. Good. Well, good luck tomorrow.
Thank you.
And then, thank you, Megan. And then Dr. Frieder, please introduce yourself, and then you can feel free to go ahead and go into our didactic.
Okay, so I'm Ariela Frieder. I'm a perinatal psychiatrist. I work at Frontier Psychiatry too. I have been working in this field for many years, and yeah, I'm happy to be here. Anything in particular, like that you want me to say more? I think.
No, I think that's good. I think we all know you. I just want to make sure that people, if the few people that don't know you yet, I want to make sure they heard you introduce yourself. So thank you.
Yeah. Okay. So let me share my screen. Yeah. Okay, I always have the same problem. How do I move this thing? Oh, 1 second. Oh, that's it. Okay. Can you hear me?
Yes.
Okay, perfect. So today we are going to talk about the assessment and diagnosis of anxiety disorders during the perinatal period. First, any announcements? Anybody wants to do any announcement in particular? Anything to say?
Dr. Frieder, I was just going to say, I'm getting ready to post the link for the Perinatal Mental Health Facebook group that we're trying to get up and running. So anyone who is on the call and hasn't joined us yet, you are welcome to join, just as a support and resource platform for providers around the state.
That's great. Thank you.
Are you going to put that in the chat, Megan?
Yes, yep, I'll put it in the chat.
Thanks.
Yes, you're welcome.
Perfect. So I wanted to mention, so you don't forget, there is a referral line. It's a state-funded line. It's free, the Prison Psychiatric Consultation line. Providers can call, and we answer the line, and we help with the treatment of your perinatal patients. So if you have any questions, or you know a provider that needs help in treatment of their perinatal patients, please tell them to call us. We answer the phone calls every day from Monday through Friday. So, and there is a call service that answers the calls at other times when we answer the call 1 hour a day, but there is a call service that answers the phone call and give us the information. So please call us if you need us. So as I'm starting to talk, I wanted to ask everyone to listen to the presentation and start thinking about any case that you might have in mind, so we can talk at the end of the presentation about this particular topic. We are going to talk about anxiety disorders in the perinatal period. So everybody is welcome to discuss a case, to bring up a case, and we can all discuss it. So just listen and see if you have any patient that resonates with you, like this material. So anxiety disorders are very common during pregnancy and postpartum. We don't know very well about the prevalence of the specific anxiety disorders, but we know they are very, very common. And actually, and we'll talk more about that, but when they are associated to depression, they are very common. Like 1 in 7 women can have perinatal mood and anxiety disorders. So it's very, very common. So we are starting to learn more and more about it. So I'm sorry. So we have few data about the impact of pregnancy on the course of the specific anxiety disorders, but what we see very commonly is that the focus of the anxiety is specific to pregnancy. And we'll talk more about this, but you will see like in terms of like in OCD, women are having obsessive thoughts about the baby, or in panic disorder, they might feel the different feelings, like they might feel shortness of breath because the uterus is growing, and they might think that they are having a panic attack because of the feeling of lack of air, or they might think that they are having a problem with their baby. So it's very focused on the pregnancy, the anxiety, and that's particular to pregnancy for sure. So why is important to know about prenatal anxiety? And I will be talking about this in different ways. And I think it's very important to tell your patients this, because women tend to think that it's okay to feel anxious, you can tolerate it, but the problem is the treatment. You know, when you take medication, that's the problem, but they don't think about the negative consequences of being anxious or stressed in pregnancy. And now we have a lot of information about it. And we know that the fetus being exposed to cortisol, high levels of cortisol, may contribute to premature labor and delivery. And also the stress and anxiety of the mother may precipitate the release of catecholamines, and that can bring up vasoconstriction, which makes that the vessels in the arteries of the mother get constricted, and there is less oxygen and nutrients going to the fetus. And with that, the fetus can't grow well. And also we know that the exposure of the fetus to maternal stress and the increased levels of cortisol can predispose the baby to having negative effects on the central nervous system development. So all this is very, very important, and we will continue talking about that. So anxiety disorders are associated with increased catecholamines, increased uterine resistance. That's what I mean with the constrictions of the arteries and decreased oxygen and nutrients to the babies, poor neonatal outcomes, babies of mothers that are very anxious in pregnancies. First of all, they can be born before time. Some of them, they can die. They can have, if it's at the beginning of the pregnancy, they can have miscarriages. Later on, babies can be very fussy, very colicky. Later on, they can have feeding problems, sleeping problems. And then when they grow, they can also have problems themselves, you know, so they can be anxious themselves or have depression. And what is very important and very specific to anxiety disorders, and we see it sometimes also with depression in the postpartum, is that the mother tends to avoid the child. And we'll talk more about that when we talk about the specific anxiety disorders. So perinatal mood and anxiety disorders are associated with negative pregnancy outcomes. And here you have a list of them. As you see, there are a lot of them. One very, very important one is that perinatal mood and anxiety disorder in the pregnancy, during pregnancy, are associated with postpartum depression. So it's very important to treat it in pregnancy so we can avoid an episode of postpartum depression and anxiety. Anxiety during pregnancy is one of the most important risk factors for postpartum depression. And we see all these negative pregnancy outcomes that you see here. We see them a lot. So 2/3 of perinatal anxiety are associated with depression. 2/3 of perinatal depression is associated with anxiety, and many times the anxiety is part of the perinatal depression. And the American College of Obstetricians and Gynecologists recommends to screen for anxiety at least once during the perinatal period. I would suggest that you screen every time you screen for depression. So if you screen 2 times during pregnancy and then 1 time in the postpartum, I would suggest that you do the same with anxiety. So they are trying to do some scales that are specific to pregnancy, but they are not yet validated. when we spoke about depression, we spoke about the EPDS, the Edinburgh Postnatal Depression Scale, that is also validated in pregnancy. That scale has some questions about anxiety. So that is good for depression and can help to recognize some patients with anxiety. If you want to screen just for anxiety, you can screen with the GAD-7. It's a very quick scale that you can use. It was developed first to use in generalized anxiety disorder, but it's also, it performs well also for other anxiety disorders like panic disorder, social anxiety, and PTSD. So you can use it also for that. And usually it depends where you read, but usually you need to get a level of 10, and that's moderate anxiety. And with that, you can do a more further interview, more in detailed interview to see if the patient has an anxiety disorder. But it's very important to screen for anxiety disorders, because sometimes with anxiety, there is a fine line. Women tell you, oh, I'm anxious, but it's hard to tell when is it what we call normal anxiety of pregnancy or postpartum and when it becomes a problem. So it's important to be aware and be on top of it and screen for it. So risk factors for postpartum anxiety are low socioeconomic status, lack of social support, and you will see that many of these are the same for depression, history of trauma, and we'll talk more about that when we talk about the anxiety disorders, history of mood and anxiety disorders, of course, high perceived stress, women with that perceive that they have a high level of stress, and planned pregnancy. You know that we have 50% of pregnancies are unplanned in the US, and medically complex pregnancies. That's also a risk factor for postpartum anxiety, and also for anxiety during pregnancy. So here you have a list of the perinatal anxiety disorders. And here you have a list of the symptoms you can see, and you will see that these symptoms, some of them are specific to the different anxiety disorders, but in some women, they don't meet criteria for a full, let's say, OCD or generalized anxiety disorder or panic disorder, but they have a little bit of each, you know, or not everything. But what you see women that they are worrying a lot, they are feeling on edge, they have sleeping changes, usually insomnia, intrusive thoughts about the baby, if they are pregnant, about how the pregnancy is going, if the baby is born, what if something happens to the baby, muscle tension, heart racing, shortness of breath, GI symptoms, and headache, physical symptoms they can have too. So something particular about postpartum anxiety is that women tend to worry a lot about the baby and about their ability to be mothers. And so they might feel they're not adequate enough to be mothers. So that's when it gets a little bit confusing also with depression, because this anxiety can make them at the end feel worthless and feel depressed, you know? They have a lot of worries. They worry, as I said, about the baby, but also about themselves. Are they good mothers? They have trouble responding to new situations, and being a mother, when you are a new mother, it's a new situation. So they might not know how to respond to this situation, to the different situations with the baby. And so they might have difficulties also soothing the infant, interacting and communicating with their baby. And they have impaired bonding, as we see also with depression. So I'm going to talk specific now about post-traumatic stress disorder. So it's more and more recognized. We have most of the information we have. It's based on traumatic birth. So after traumatic birth, It's associated usually with intense pain, sense of loss of control, and feeling powerless during labor. So women really feel out of, like they don't have any control. And sometimes we can say, like you can objectively think it's not traumatic, but they live it as traumatic. They live the situation as they had no control. And there is much literature about the psychological reactions to pregnancy and infant loss. And we see that these reactions in the literature can be either post-traumatic stress disorder, they can be anxiety, depression, loneliness, isolation, dissociative experiences, and somatic symptoms. So there are different ways of responding to a perinatal loss. But we'll talk in particular about PTSD. So what is the prevalence of PTSD? So in a recent systematic review and meta-analysis, they saw that PTSD, the prevalence was 3.3% during pregnancy and 4% in the postpartum. And as I said, mostly it's in relation to traumatic events during birth. There is less information about PTSD because of other reasons in pregnancy and postpartum. But when they looked at a high-risk sample, they saw that the prevalence is much higher. And these women, we are talking with severe complications in pregnancy or during childbirth, like premature birth, after emergency C-section, or after stillbirth. And they saw the rates of 15 to 18%. And as I said, like, we don't really know what is the real prevalence in the postpartum of PTSD, because most of the studies just look at traumatic childbirth experiences. So this is very important. This is the clinical part that you will see. So, and this is described in the literature, that traumatic events, we see it with women, you know, may lead to avoidance of the baby, of also future decisions about having children and about sexual experiences. And it has been written in the literature about women that requested terminating an unplanned pregnancy or sterilization. And some women avoid contact with their kids for many years. And some women avoid relating to other mothers and kids, you know, and that brings more isolation. And women with history of sexual abuse may re-experience their abuse during childbirth procedures or during internal examinations. This is very important, and that's why you want to have a communication with the OBGYN and to have so they are aware of this woman's history, because these women really need like a trauma-informed care. You know, they need their OBGYN to be respectful, to explain to them everything, what they are going to do. Some women will want just the women to see them, like they might have their preferences where they feel safe. They need to feel safe in the experience. So that's very, very important. In terms of panic disorder, so there are, and we'll talk in the next slide about that, but there are some theories about if panic disorder is more frequent or not during pregnancy, but there are some things that we know, that the increased heart rate and respiratory rate that happens during pregnancy can contribute to anxiety attacks in predisposed women. So women with anxiety attacks are more in tune with their body sometimes, and they might be more aware of these changes in their physiology, and they might feel like they might say, oh, okay, like they feel their heart racing and they say, oh my God, I'm having a panic attack, and then have a panic attack. On the contrary to that, the progesterone metabolites are active at GABA receptors, and that might help protect against anxiety attack. The other thing that happens with panic disorder and anxiety, it can induce a hypercoagulable state, you know, so women can have clots. And as I said before, not just for the panic disorder, but anxiety disorders in general are associated with preterm delivery, small for gestational age, hyperemesis, increased miscarriage, low birth weight, preterm delivery, and C-section. So I'm going to repeat it a lot of times because it's the same way I tell my patients, is that they need to know the negative effects of their illness because they don't think about that. So some studies suggest that there is a reduction in severity and frequency of panic symptoms during pregnancy, but other studies say that that's not the case, that actually there is a persistent or worsening of panic symptoms during pregnancy. What seems to be more consensus is that the postpartum period appear to be a period of vulnerability to increase in panic symptoms, both new onset and recurrence. And a predictor, like how to know who will have symptoms in the perinatal period, might be, and this in one study that I could find, is that it might be the pre-pregnancy symptom severity of the woman. And so what I was telling at the beginning is that women can have their symptoms specific to pregnancy, so they might interpret their panic attack as during pregnancy as an indication that something is going wrong with the fetus. So, as I said, the anxiety might be directed towards the pregnancy. And so I was trying to figure out what was different, you know, in terms of panic disorders in pregnancy or postpartum than not. And in one retrospective study, I found that postpartum panic disorders, women had more psychosocial stressors during that period. And also what is very interesting in other studies, there is some evidence that lactation can be protective against panic attacks, while weaning can bring up panic attacks. But these were retrospective studies, so this needs to be corroborated with more data. What is very important about panic disorder is, like when you have a woman with new onset of anxiety symptoms, is that you need to do a medical workup. You have to send them for medical evaluation, because more in pregnancy, there are certain medical illnesses that can manifest with anxiety symptoms. So if the woman is hyperthyroid, if the thyroid is functioning not well, she can have anxiety symptoms. If the woman is anemic, she can have anxiety symptoms. If she has preeclampsia, she can appear to have anxiety symptoms. So it's important to send them for an evaluation to make sure there's nothing physical going on. So in terms of obsessions, and obsessions about harming the infant are not specific to OCD. So not everyone that has obsessions has OCD. So first of all, they are reported in about 40% of women with postpartum depression, and also in about 34 to 65% of new parents in a volunteer community sample when they did a study. And the thoughts were more like, obsessive thoughts were more like passing in this group of women, and mostly they were thoughts about sudden infant death syndrome, and with the compulsion to check on the baby. And what was very interesting when I was doing the research on this data is I found also fathers with postpartum obsessions. It was a small number of fathers, but they also saw fathers with postpartum depression. So initially, we didn't know much about OCD in pregnancy and postpartum. So usually it goes undiagnosed and untreated. But now we are starting to have more and more information about it. And what we know, it seems that women seems to be at an increased risk of new onset OCD or recurrence during pregnancy and postpartum. So both the new onset, but also a worsening of symptoms if a woman has a history. What is interesting about OCD in the perinatal period and basically more in the postpartum is that there is a lot of thoughts about infanticide, of harming the child, you know? And again, obsessions are unwanted thoughts, are intrusive thoughts that come to your mind that you don't want to have and you don't agree with. So they are very distressing. We'll talk more a little bit about it. And some of them can have thoughts about child sexual abuse. They provoke so much distress that women take long steps not to act on them. So they avoid their triggers, you know? So if the child is the trigger, they might avoid the child, you know? And like I had a patient that she was thinking about harming her child with knives. So she actually was avoiding knives to the point that she was telling me that one day she was trying to eat chicken and she was trying to cut it with a fork because she couldn't use a knife because it was triggering her. So it's very important to differentiate from infanticide ideation, and we'll talk more about it. And it's very comorbid with depression. Usually women start with the OCD, but they get so upset about it that they get depressed after that. And OCD has an abrupt start in the postpartum. So I wanted to show you this. This is a chart that shows the difference between postpartum OCD, postpartum psychosis, and postpartum depression. So all of these can have symptoms that seem like obsessions, and you need to recognize them and see what to do. Most importantly is to differentiate between obsessions of harming the child and infanticide ideation, like really wanting to harm the child. So in postpartum OCD, the thoughts are ego dystonic. They don't agree with the thought. They don't want to act on the thought. And the thought triggers a lot of fear and distress. In postpartum psychosis, they don't feel that fear about the thought, you know, like it makes sense to them that they agree with the thought. And postpartum depression, it's an obsession, and it can trigger fear, and it's upsetting, and it's unwanted, but it's also associated with other symptoms of depression, like depressed mood, hopelessness, helplessness, negative cognition about themselves. And here you see like that also in postpartum psychosis, they can have other psychotic symptoms, you know, hallucinations, delusions. And in postpartum depression, they can have psychotic symptoms, but they are usually congruent with their mood. So they might have like the belief, you know, that they are really bad, that they should die because they did something, they did a sin, like they become delusional, but it's congruent with the negativity of their mood. So the obsessions in postpartum OCD cause a lot of distress, and in postpartum depression too, but not in postpartum psychosis. So I think that this is very important to know the difference between these three. Sometimes it's hard to differentiate between postpartum OCD and postpartum depression at the beginning because they can come together, and also because postpartum depression can have obsessions and maybe not meet criteria for full OCD. But the important thing is to differentiate it from postpartum psychosis. So any questions?
I don't have a question. I just had a quick thought. One of the things I really emphasize when I'm working with patients, especially with OCD and some of those really distressing thoughts, is just reiterating that just because it's a thought, that doesn't mean you're going to act on it. And so like you're not crazy. This is very, very common, especially for new mamas, around the health and safety of the baby. And so just really trying to normalize that thought to a certain extent, because these thoughts really freak new moms out and they get really scared. I'm going to hurt my baby, something bad's going to happen. And so just really trying to normalize it and reassure them that just because it's a thought, that doesn't mean we have to act on it.
Yeah, and you know, I agree totally. And the other thing I want to say is that it's not just it scares the woman, it scares sometimes the mental health provider or the health provider that sees them, you know, because I had patients come to me and tell me that they were sent to the emergency room because of these thoughts. They were told they were crazy because of these thoughts. So it's not just scary for them, you know. So like there needs to be a lot of education about this for the woman and for health providers.
I had a, can you guys hear me?
Yes.
Sorry. Yeah, one thought I had is I think we all I think work with a lot of men and women who've been exposed to significant trauma, and certainly the population we work with. I almost wonder is anybody opposed? And I guess I'll put this out to everybody. Is anybody opposed to? I would assume trauma unless proven otherwise. And especially when you're thinking about, what Dr. Frieder said around, the re-traumatization that's potentially experienced, during childbirth and sort of intrusive exams. I mean, at least with most of my patients, I just assume trauma until proven otherwise. When I ask them and that they say no, okay, no, but otherwise, I almost wonder if we just need to assume.
I agree. I think a lot of women will not talk about it at the beginning, like it takes a lot of time for them to open up and feel safe and talk about it. And yeah, I had a patient, it took her 8 years to talk to me about her trauma, so I agree.
Sometimes even if they don't recognize that this is trauma and that the perinatal period can be such a triggering time for that trauma. I have a patient who she had a lot of just really inappropriate sexual touch when she was a kid. And it's not until she did some infertility treatment and she's being poked and prodded all the time and she's having all sorts of exams that a lot of that stuff came up for her. And so, and prior to that, she didn't really recognize that, hey, this was trauma and this is something that happened to me that's now impacting me.
It makes me think about when, we get clients in the pregnancy period and, kind of taking on that doula role sometimes, where you're really kind of teaching clients how to advocate for themselves. What are their rights in the medical environment? Because kind of in the mindset that like, oh, it's probably a lot of trauma that they're experiencing. I think we're also in the mindset, well, we're going into a traumatic environment, most likely, in some form or fashion, and how to kind of prepare clients for engaging in that kind of environment, especially with a traumatic background.
Just a little personal story. I am a postpartum OCD survivor, and I have no awareness of any sort of sexual abuse that happened to me, but some of the thoughts I had were related to that during diaper changing. But I was part of a child abuse prevention team with my work, and I saw a lot of really graphic photos and heard graphic stories and read graphic footnotes about child abuse. And I was young and sensitive and had never heard of secondary trauma before. Now, I don't know if there's any research on it, but in my personal kind of healing, I've kind of just said, I think that I had some secondary trauma and that I didn't realize I was carrying around. And when I had my own baby, like those things I was carrying came through. Now, who knows? But I thought I would offer that because we don't always talk about secondary trauma and exposure to violence and having that come through when it hasn't necessarily happened to us. But I think those protective moments when our drive to just be protective and we're so tired comes on. Sometimes I had thought like, oh, I understand why mother spiders like eat their babies, you know, like it was just like I was so entirely exhausted. I was like, wow, maybe this is some deep like, you know, evolutionary, you know, thing. But that's my personal experience, and happy to answer any more questions about it.
So did you find that you went a little too far, like when you were biting your baby's toes and you kind of started nibbling a little too hard, and
Right?
is that what happened?
Oh,
Yeah.
Thank
Thanks
you
for
for sharing, Bri.
yeah, you're welcome.
But I was thinking, you know, sometimes it's not just what that it's like something what is defined as trauma, it's what you perceive as trauma, you know, like, so in terms of the medical environment, when you go for labor and delivery, you know, it might be that if you ask another person, they might not see it as that way, but for you, it was traumatic, you know, and that's what is important, and how you live it.
Yeah, that's a good point.
So anyone have any case that they want to discuss?
Well, I have a question about sort of preemptive management on somebody who is very high risk for having postpartum mood issues because they have mood issues. And so for somebody who's at increased risk of anxiety or even psychosis, how much counseling or anticipatory guidance do you give them heading into the postpartum period?
So it really depends what we are talking about, you know, like, because one thing is anxiety and depression and one thing is psychosis, you know, but I think, like, anyhow, if somebody is high risk, you have to follow them closely during the pregnancy with psychotherapy and a psychiatrist, you know, like both, you know, and try to work through their issues during the pregnancy and try to address their issues during the pregnancy so they can have a better outcome in the postpartum. If it is anxiety and depression, you know, sometimes with psychotherapy might be enough, you know, and then that's why the psychiatrist is important. I meet with my patients every month, even if they are in therapy, because I need to assess them and make sure, even if they are not on medication, just to assess them and see if they need the medication at some point. In terms of psychosis, that's a little bit more difficult and more complicated, the situation, and it depends on if they have a history of psychosis, are they psychotic now? If they have a history of psychosis, and I had patients like that, you meet with them frequently also, and you try to figure out why was the psychosis, what was the reason for the psychosis, what is the diagnosis? And that will take you to make a decision of what kind of treatment they need. Do they need treatment with medications during pregnancy, or can you start the treatment at the moment of the postpartum, immediate postpartum, you know? So it really, really depends. But I think all of them need psychotherapy. They need the guidance, they need the support, you need also that help. You need somebody else to keep seeing them and communicating with you.
So I know she has like a counselor that she really likes. So she was diagnosed with bipolar during like her 3rd trimester and was started on Lamictal. And she has a history of trauma. She's a history of substance use, been clean the whole pregnancy. We're so, so proud of her. But I worry about, like, we tend to obsess in pregnancy and then leave them a little bit naked coming out of pregnancy. And so I just, for her, like, I was wondering, like, well, do I tell her, like, you know, you're at increased risk for these disorder. So like who's around that can keep an eye on you, or if you have, you know, I don't know how much like prompting to give her, because I don't want her also to worry that she's having an anxiety disorder or a psychotic disorder or something.
But, you know, I think in that particular case, or in those situations, you have to take it very seriously, you know, because bipolar disorder is associated with psychosis in the postpartum, you know, so they need to know that, you know. And also, I see a lot of women with substance abuse that they stop using during pregnancy, but they relapse in the postpartum. So I actually follow them very closely in the postpartum, you know, in the immediate postpartum. And for the first 6 months, I follow them very closely because I'm concerned about both, you know, a relapse of their mental illness and the relapse of their substance abuse. And one very important thing is to involve the significant other, the family member who is most important. I always involve them and I bring them to a session close to the end of the pregnancy and I discuss the red flags and I make a plan of how to reach me and what to do in different scenarios, you know? I think it's so important because they can get really, really sick. It can be very scary for everyone, and they can hurt themselves and they can hurt others. So it's something to take into account.
Thank you.
Anyone else?
Oh, I'll pick on someone. I don't care.
I have a medication question, not so much an assessment. Whoops,
Okay.
sorry, I did myself. I have a client that just got prescribed nifedipine, which is a vasodilator, right? It's
for hypertension.
Yeah. She got prescribed it. She's breastfeeding, so she's got, 3-month-old now. And, was experiencing breast pain, thought she might have Raynaud's syndrome. And so talked to her lactation consultant, and then got directed to her nurse for OB or something and got prescribed nifedipine. And I was just wondering if that would also have potential support for some of those anxiety symptoms, just being a vasodilator a little bit, kind of, would it be a...
Usually for some types of anxiety, we can use another medication that we can use for hypertension, that is propranolol, that is for a specific kind of anxiety, like performance anxiety. I don't know, Dr. Azobi, did you hear about using nifedipine for anxiety? I
was just curious if it was ever, or,
So yeah, so Caitlin, so to be honest, so I had to look up because I forgot the mechanism of how nifedipine works, and so nifedipine is I just looked it up. So this is not me being smart. I had to look it up. So it's a calcium channel blocker.
Yeah.
See, Dr. Frieder knew it. I didn't know it. So it's a calcium channel blocker, and what's different? This other medication called propranolol, which is a different. The mechanism of a propranolol is a beta blocker, which pretty much it turns down the volume on fight or flight. So it's more closely linked to the mechanism of anxiety reaction, whereas the calcium channel blocker is more related to the muscles that open and close blood vessels. So again, the propranolol is probably more effective for anxiety than a calcium channel blocker, which is probably not touching the anxiety part of what somebody's experiencing. Does that make sense? Would you agree with that, Dr. Frieder?
Yeah, yeah, totally. Yes.
That's
Yeah.
helpful to understand. Thank you.
Yeah.
So then to follow up on that, would you guys recommend Caitlin, because it's kind of like tricky territory then, does the therapist try to talk to the doctor about, is this appropriate for our client?
And maybe should we consider something that might
Right, yes.
dually support both of these things?
But the thing is, like for right now, you use those kind of medications, you know? So I wonder more about the patient, what other symptoms and what they are treating, you know? But if it's just right now, I'm pretty sure they use nifedipine and those kind of things, you know?
Yeah, I feel like their assessment of Raynaud's was like not thorough. It kind of seemed like oh, that might be what's going on. We'll try that kind of assessment. So I wonder if you might be open to just consulting.
But you're talking about something important, you know, the communication between providers, you know?
Yes.
Like it's so, that's why I was saying to Casey when she was talking about her case, you know, it's so important to have like a team, you know, a therapist and like me as a psychiatrist and the OBGYN or the NP, and like have like a team working together with these patients, because if you work alone, like you miss a big part of the patient's health, you know?
Exactly. I need to connect.
Yeah.
Well, I think the other thing too is as I think we all know this, right? It depends on the physician or the other provider that you're talking to, right? Some people are open to having communication and don't have their ego injured easily, and some are more problematic. And so, yeah, so that's obviously something which obviously we all know is not ideal, because the patient gets lost.
Yeah. So I have a case. If nobody has a case, I can talk briefly about a case. So I actually saw a patient last week. She is 6 months postpartum now, but she started having obsessions as soon as the baby was born. And she has a history of obsessions, but never to this point. So the obsession started to be that the husband wanted to buy a barbecue, a grill. And she started thinking that they are going to grill the baby. So she couldn't think, like she didn't want to buy it. Like she was like really no, and really telling her husband, no, we can't buy it, and getting very upset about it, and couldn't stop thinking about it, repetitive thoughts. But she knew it didn't make sense, but at the same time, she couldn't stop thinking about it and being terrified about it. So she wanted to avoid the grill. So she saw a psychiatrist like 1 month postpartum for this, who suggested she start the medication, but she was breastfeeding and she decided not to take it because she was breastfeeding. But now she realized that the symptoms are getting worse, and she came for help. So I was wondering, what will you do with somebody that has intense obsessions to grill their baby? Like, she's very anxious. She goes out, like, you know, with COVID, she was isolated. She was home. She didn't have to go out. But now with the reopening and everything, she started going to some social situations and realized that she's very anxious when she's around people because of her thoughts. Like, she can't share her thoughts. She feels like she's crazy.
So my first thought is really using it like a really strong CBT approach with her. So really working with her to identify these thoughts, challenge them. Where's the evidence? Like, where's the evidence that you're going to put your baby on the grill? And then putting safety stops in there as well. So, okay, we're not going to turn the grill on unless, let's say, husband's there. And even if you think you're going to grill the baby, we know husband's not going to grill the baby. And so really just working with her to challenge the thoughts and kind of re-engage that logical part of her brain when the obsessions take over. And then refer to you for medication.
So I had so if I may, I guess my first so I agree with all that obviously, but the other thing I guess that I'm feeling that I want, if she comes and starts talking to me like this, I guess my first thing, because it's ego dystonic, right? Because these thoughts are making her upset. I would say to her, I would take the leap and say to her, you know what? You're not going to grow a baby. I know you're not going to do it. So you're fine. So I just want you to know that, number one, right? And so because I just worry about the cycle, like I want to grow a baby. Oh my God. And what if I do? And I think she probably wants to hear also from a professional. And so I'm going to assume I'm a professional for now and say that you're not going to grow a baby. It's not going to happen. But I understand what you're thinking. And then launch into kind of what Megan was saying, is really getting into the tactics now about how to help reinforce that and say, okay, let's say one day you feel like you're actually going to go grill a baby. Well then, all right, then you can do kind of, you put the safety thing in place, right? So there's no way you're going to grill a baby. I don't know. So that's kind of what I would hope to do.
Yeah, I do that. I do that a lot because I have patients that come and tell me I'm going crazy. I need to go to the hospital. And I'm like, you don't need, you are not going to act on your thoughts. I know it, and so I kind of want to give them my security, my feelings of security that I know they are not going to do it because I know they are not going to do it. So I agree. Yep. That's my first thing that I do. And then, I send them to the therapist to work on the coping skills and the CBT, and then I give them medication. Yeah.
One of the things that I think about too, because I like this idea of kind of being present with what that current flow is and kind of curbing that, right? And I like also what Megan's talking about of really confronting the logic of it. Well, is this true? How do you know it's true? What would it mean if it's not true? But then I also really this is such a thought focused thing, right? And there's so many other channels to get on. So I often really kind of try to teach clients about getting on a different channel. So, instead of that thought channel, we got our imagery channel, we got our movement channel, we got our emotion channel, we got our sensation channel. And so, maybe shift in that environment. Okay, we go take a time out in the bathroom and we check in with our sensation channel. What are we noticing in the body in this moment? If your body could talk, what would it say it needs right now in this moment? Oh, maybe it does need a little water. Let's have a little water break together. Okay, so now we're shifting the channel, shifting the experience, and really focusing on those somatic sensations of what's happening and really moving into those needs. Our body is just talking really and trying to express what it actually needs. And I feel so much of the time we just have a little bit of nutritional, hydration need to really shift the channel and get on a different track.
That's important. I didn't think about that, but it makes a lot of sense.
That's beautiful, Caitlin. I was undiagnosed for a long time and pretty much had to help myself, I guess. And I do remember thinking okay, this is a waking nightmare. I'm just so tired. I haven't got to process any of my stress. And anytime that I'd have the thought, I would start singing a happy song and I'd be like, I'm stronger than my thoughts. And then I'd start singing. And so every time it would start coming, I would be like, no, you don't get to come through. And then I'd say, we're going to sing now. And it was getting control of my thoughts. Yeah. And changing the channel is a really great way to describe that.
And isn't that, and sorry, for those of you that know more about this than I do, in terms of, isn't that just another way of really doing mindfulness? In other words, what you're doing is you're bringing up another feeling and then kind of immersing yourself in that feeling which kind of crowds out all the other stuff. Would that be accurate?
Totally. What you focus on grows, right? And so I'm often trying to invite people to shift their focus to noticing, where do you feel relaxed in your body? Like, where's that one place in your body you do feel relaxed? Where do you feel pleasure in this moment? And can we tap into pleasure right now versus postponing? Because our culture is all about postponing pleasure. After we do that run, we'll have our cookie or whatever. Like, what about the pleasure in the moment? So yeah, mindfulness and really just somatic awareness of these sensations, you know. And, you know, I think more attunement to those sensations, that we start recognizing, oh, I have a similar sensation after I have a caffeinated beverage. I'm going to get curious about that.
That makes sense.
You guys, I apologize. I need to jump. I have another appointment I have to jump to. Thank you. You guys are great. Thank you.